All right, welcome to Cardiology 3. If you've made it this far and not quit, you're insane. The last couple of classes have been, from the look on your faces, the equivalent to brain rape. But that's okay, because you consented. You paid to be here. Remember that. So we've talked about remembering and going over the anatomy, the structures, the physiology, electrophysiology, conduction system of the heart. We've talked about the ion pump channel that creates electrical energy depolarization through the myocardium. And we've also talked about how to actually follow a systematic step process to read EKGs. And the most important factors being really just following your steps systematically and memorizing the criteria for these rhythms. That's really all it is. It's all just pattern recognition at this point. You can church it up and make it more complicated than it can be. But again, at the end of the day, too fast, slow it down, too slow, speed it up. And if it looks really, really funny, hit it with some kind of big drug. It cannot get simpler than that. I understand this is a lot of information and that it's going to bear repeating. Give yourself some grace, though. We are covering this at a lot of material in a very short amount of time. The entire month is devoted to cardiology. And then after that, we've got guest speakers coming in to, rehash, revisit all this material. And then we have ACLS for two reasons. One, ACLS is a requirement to be a paramedic in the state of Georgia. It's also going to pretty much cover everything from head to toe, again, in the cardiology area, static and dynamic cardiology, how to run a mega code per the AHA guidelines. And again, it's not sorcery, it's science. You can resurrect the dead if you follow the steps to the dance. And that's also going to be a good recap of what is going to be happening on your cardiology exam that I'll give you. But ACLS, PALS, AMLS, that is word for word what's going to be on your National Registry test. Word for word. So without further ado, let's talk about it. All right, so just a quick reminder about a visual. Some of you are visual, right? You would agree with that? So a visual of the electrical events in the heart. We have, again, the P wave created by what? The SA node discharging electrical energy. And then it transferring that energy along the intranodal pathways, dispolarizing the entire atria, right and left side. That energy is then transferred to the AV node, who will hold it for about 0.05 of a second. Martin, why would it hold that electrical charge? Give ventricles time to fill. Very good. You've been paying attention? A little bit. Look at you. All right, then we're going to transfer that energy down through the bundle of hairs and split it left and right side. Those are called bundle branches. Those bundle branches will then do what? Send it off to the Purkinje fibers and let the ventricles become depolarized as well. And you can see the progression through this picture of how the wave is created as that electrical energy returns all the way back from the atria to the ventricles through the process of depolarization and repolarization. So the P wave is atrial depolarization. QRS is ventricular depolarization. And of course, the repolarization of the atria occurs somewhere in that QRS wave, but it gets hidden in there. What process is that called? What hides it? It's called fusion. Fusion. Remember Goku and Vegeta? Fusion has occurred, so it's pretty much disappeared off in there. But we do have an actual wave generated when we see the myocardium repolarize the ventricles. What's that guy called? T wave. Important concepts to remember about the T wave is what? We have refractory periods. We have an absolute refractory period and a relative refractory period. Tell me about the absolute refractory period there, Chamberlain.
It can't be stimulated to repolarize it.
Very good. During the absolute refractory period, absolutely nothing will cause a secondary stimulus to occur within the myocardium. But that latter half, the booty end of the T wave, is the the relative refractory period. In that space exists what? Opportunity for a secondary stimuli to be produced. Now we're talking about things like commotio cordis. That could be what? What do you think, Tyler Kuhn? Yes. In reference to the relative refractory period. Okay, so a patient receiving a blunt force trauma to the heart and the myocardium, and during that electrical sequencing right there, at that exact time could produce a secondary stimulus and cause the patient to go into V field. Sounds good. So today we're going to talk about arrhythmias. Exactly. Arrhythmias. I'm going to tell you about the who, the what, the when, the why, how to recognize and identify these arrhythmias. So we're going to talk about the nature of their origin, their magnitude, how bad they are, which means how aggressive you should be when you see them. Ones that originate in the SA node, atria, AV junction, ventricles, and other disorders of resulting from conduction. So the dominant pacemaker of the heart is who? What do you think? Wrath. SA node, sinoatrial node is the king. There is a line of succession though. If the king dies, there is somebody to take his place. The AV node, then the bundle of his. Progressively, you'll see EKG changes that are highly identifiable if you've memorized the criteria, because based on how the EKG represents, the waveforms will change, the appearance, the morphology will appear differently. And you can tell who's pacing the heart based on the morphology of the wave, the speed of the wave, lots of different criteria. So we're going to start with the SA node. Rhythms that originate in the SA node are going to be sinus brady, sinus tach, a sinus arrhythmia, sinus arrest, sinus block, sinus pause, sick sinus syndrome, and of course the old normal sinus rhythm. Normal sinus rhythm. So, significance of sinus rhythms. They're associated with patients. You will assess your patients and find them to have some type of rhythm that could be symptomatic or non-symptomatic. Is it idiopathic? Is it normal for them? All this will come from your history taking. Your treatment will be derived from your assessment. So when we're saying, are you symptomatic or not, we're saying what? Are you experiencing chest pain, dizziness, weakness, fainting, marked blood pressure drop? That means you are hemodynamically unstable. Now, based on being stable versus unstable will determine what level of treatment you get. Am I going to be gentle and non-invasive, or am I going to perform a very invasive style of treatment? This could range from anything from a vagal maneuver to a electrophysiological response that we give from the cardiac monitor, such as cardioversion. So symptomatic, what does that mean? What do you think there, Sloss? You're doing good. Come on. Experiencing symptoms related to what?
Symptoms related to issues that could potentially indicate something other than it is. So if I'm having chest pain radiating to the left side, it might be indicative of
Okay. So you're not wrong, but let me clean it up a little bit. So symptoms related to cardiac compromise, that is a rate dependent issue, because cardiac output is rate and stroke volume, heart rate and stroke volume. So if I have a rate that is like a sinus brady, that is like a rate of 30, I won't have the cardiac output to have enough pressure or blood flow to my brain, heart, lungs. It could also be an issue affecting stroke volume. We said we had issues with patients having, let's say, a sinus pause or a sinus arrest, which means that the SA node just ain't firing. And there's going to be a blank slate there in between your EKG. There's going to be a period of asystole. Is that healthy? No. We're going to might have some rate dependent issues, but is it causing them problems or not? Because if it ain't broke, do you have to fix it? You don't have to fix it. So if it's not causing the patient issues, you don't actually have to jump on it. But if it is, you need to be aggressive and go after it. And I can tell you, like, every time I've cardioverted somebody, I've always had little butterflies in my tummy. What does that mean? It means I was nervous about it every time. You should feel that way about riding a motorcycle or a horse, because it could throw you. Respect the horse. It might be having a bad day. Am I lying? No. I've been bit by a horse. Good for you. Builds character.
They have bad days just like you.
They do. I give them sugar. They usually chill out. Same with women. I'm recording. Oh, well. So let's talk about it. Normal sinus rhythm. Y'all was able to identify normal sinus rhythm in the last lecture. Everything's normal. What are our 5 steps to identifying a rhythm? Let's talk about it. Heart rate, rhythm, regularity. Is it regularly? Is it regular? Is it irregular? Is it occasionally irregular, or is it irregularly irregular? Is it complete chaos, or can I put like a kind of a rhythm and see what's happening? Every 3rd beat, there is a PAC. That'd be like atrial trigeminy. It's regular. It's got a pattern I can follow or identify. So my first step is rate. Based on rate, I know that normal is 60 to 100. Anything below 60 is bradycardia. Anything above 100 is tachycardia. Based on rate, I can include and exclude a lot of rhythms. If I have a rate over 100, I know the last name of this rhythm is something, something tachycardia. That helps a lot. So if you're taking an ABCD like registry style test, that helps a lot. So next was rhythm, regularity. Does the R to R match the same distance apart? Does the P to P have the same distance apart? There is some room for a slight differing in length. How long was that? Okay, 1.5 blocks, so 0.06. If it's within that, then yeah, it can still be considered regular. There's a little bit of a leeway there. If it's anything beyond that, it's considered irregular. Irregular. Next, we want to evaluate the P wave. Is there one? Is it Russ, rounded, upright, symmetrical? I made that up. I didn't steal it from Chamberlain at all. Next year's class will believe that. I look smarter. So the P wave, is it pretty and upright and rounded? Or is it jagged and raggedy looking? Is it coming from the SA node? Because if it's rounded and upright, it is coming from the SA node. If it's not, it'll look different. It'll be spiked or weird looking or have 2 heads. P wave, is it present at all? Next, we evaluate the PR interval. The PR interval indicating what? The length of time it takes for the conduction to travel from the atria to the ventricles. Basically, how long the AV node's holding that impulse. Normal ranges from 0.12 to 0.20, which is 3 to 5 tiny 1 millimeter blocks. How much is each one of those little 1 millimeter blocks worth, Baker? Did you just give me the right answer? Wow. All right. Won't he do it? 0.04 is the right answer. Next, we will evaluate the QRS complex, which is it big, wide, and juicy? Is it narrow? Is it bizarre looking? If it's wide and bizarre looking, you can tell that's coming from the ventricles. If it's less than 3 blocks wide, which is less than 0.12, then it's within normal limits. Anything beyond that is a ventricular origination. Those are the 5 parameters that you look for to identify normal sinus rhythm. If it's 60 to 100, if there's a normal regular R to R interval and P to P interval, if the P wave is there, present and upright and pretty, if the PR interval's 3 to 5 blocks, and if the QRS is less than 3 blocks, you're looking at a normal sinus rhythm. Normal sinus rhythm. Everything lines up. Let's take a look at one. You want to see one? Yeah. All right, so we have a normal sinus rhythm. Pretty upright P, regular R to R interval. Regular also P to P interval. You're going to be tempted to skip a step. Let me reverse you back. When you're doing rate and you're counting your 6-second strip and you're counting your QRS complexes, count your P waves too. But why? So you can see if there's a 1-to-1 AV conduction ratio, 1 P wave to 1 QRS. Find the atrial rate and make sure it matches the ventricular rate. Next, check the regularity of the QRS complexes. Big spike to big spike is at the same length apart. Then do the P waves. Are they the same distance apart? Next, let's check that PR interval. It should be a normal PR interval of what? What do you think there, Thornton?
0.12.
Very good. 12 to 20. 0.12 to 0.20, which is how many blocks? What do you think? Sloss.
3 to 5.
3 to 5 blocks. Very good. Then the QRS interval. How wide is the big spiky thing? And that should be at least 3 blocks, at least how many blocks wide? 3 or less. Should be less than 3. Less than 3. Very good. So, is there any grouping or any drop beats? Now, what does a drop beat look like? It means a missing QRS complex. If there's one missing, there is a reason. What is that reason? Could it be sick sinus syndrome, a sinus pause, sinus arrest? Could it be some type of sinus arrhythmia? Could it be a machine malfunction? We have to look into that. So, again, I'm going to beat you today with repetition. Are you ready? Lovely. So, how do I, again, address this rhythm? If that other information was not up there, how would you address that rhythm? You would ask 5 questions of the rhythm. You would follow your 5 steps. What are my 5 steps there, Tyler? Rate, rhythm, quality, P wave. That's it. That's 5. You're going to be tempted to try and skip steps or just look at a rhythm and be like, oh, it's this. I promise you, be systematic every time. Take your time with this. Do it right or do it twice. Again, could the interventions you do be affected by the wrongful interpretation of a rhythm? Very good. Very much so. So ask these 5 questions. If it is a rate of 60 to 100, has a regular atrial rhythm, regular ventricular rhythm, P wave is there and it's upright and pretty, has a normal PR interval of 3 to 5 small squares, and has a normal QRS interval of less than 3 squares, we're looking at a normal sinus rhythm. What is the significance of a normal sinus rhythm? Ain't a lot. It's a normal cardiac pattern. But again, I urge you to ask people. I urge you to ask people if it's their normal, because you know what? There are abnormal, atypical people that present with different type of rhythms. Like there was this old EMT that was worked at Sumter County's 911 in South Georgia. He chain smoked like a freight train. And he was at 29 years in, he was laser in hell. Bit overweight. I know I'm describing most of EMS now, but great guy, man. He could put that ambulance and back it through the eye of a needle. I mean, he was great trucking. I mean, great partner. But his normal heart rate ran about 105. That was his normal. Why? Was it all the energy drinks? Was it the chain smoking? Was it all the cheeseburgers? Or was that just his normal? I was curious. So on multiple occasions, when I'm checking my truck off, I would take the pulse ox, right? And I'd put it on his finger just to I'm going to check the pulse ox, make sure it's working today. You know how they do. They don't replace the battery, blah, blah, you know, make an excuse to check this dude's pulse. It literally ran over 100 beats a minute every time I checked it. I finally asked him, I was like, what's wrong with you? And that was his normal. He's like, even when I go to the doctor, it just runs that way. So your body stays in a constant state of stress. Me too. It just doesn't show it. So ask these questions. We had a girl in the 2020 class who her blood pressure ran 90 over 90 systolic, which if you saw that, you too, you're 80 over 50, you disgust me. What's wrong with you? I don't either. I don't know what's wrong with you either. But that's your normal, right? And if I saw that as a paramedic provider on the streets, I'd be like, initially I'd be concerned, but you're sitting here talking to me. We're having a conversation. There's no symptoms being produced. Always take that extra time to do the history. Like, that's a low blood pressure. That don't freak you out any? Is that normal for you? That'd be important to ask her, would it not? How many people are actually doing that though? No, not many. Oh, you are? Of course you are. Well, you're at Station 5, right? The good hands people. BLS engine to the rescue. Oh, is it? Wait, who's the medic there? Let me judge that. Don't answer. I'm recording. All right, so we've talked about normal sinus. Everything lines up perfectly. What about sinus Brady? Well, everything's normal except the rate. It's just below 60. It's got a perfect R to R interval. You got a normal heart rate of 48? The hell's wrong with you? Stop doing drugs.
I used to be I used to run this.
Oh, you used to run marathons and stuff? That's gross. No wonder.
It's been a long time ago.
I walk to work in the building sometimes, about as much cardio as I get. I don't have a problem. I can quit anytime I want. I can dig it.
I was way better.
So let's break it apart. Brady means slow. So the only identifying characteristic for this rhythm for sinus Brady is the rate. What else do we look at? The rate is less than 60. R to R interval is normal and regular. The P to P interval is regular. The P wave is rounded upright, showing you it's coming and originating from the SA node. The PR interval is 0.12 to 0.20. It's 3 to 5 blocks. QRS is less than 3 blocks. Everything's perfect, but the rate is less than 60. That's it. But that doesn't mean that a sinus Brady can't cause some havoc. What is cardiac output? Sloss, we just went over. All right, stroke volume times heart rate. And if the heart rate's not fast enough to meet the metabolic demands of the body, we could see some problems occur. Like they're losing consciousness. Why? The brain ain't got enough blood. They're having chest pain. The heart ain't got enough blood. They're having trouble breathing. The lungs ain't got enough blood. They're pale, cool, clammy. They're in a type of shock that is caused by their rate. What else? Their blood pressure is low because they just don't have enough beats to meet the needs of the body. Now, why does a sinus Brady happen? It could be a disease of the SA node. What else? Could be in good cardiac condition. Very good. All right. Could have a later sign of opioid overdose because they're bradying down. How about vomiting? Could that lower that heart rate? How about vomiting or diarrhea? Basically Taco Bell. I'm not lying. All right. Respiratory depression. Hypoxia can cause it. Hypothermia. Electrolyte imbalances. Digitalis. What was digitalis again? Comes from the purple foxglove plant. We would see a patient prescribed digitalis. It's cardiac glycoside. I made y'all do a whole thing on it. Sounds like I need to do another one. No? Well, I better hear an answer soon. So it would be normally prescribed for patients if they had like chronic AFib or aflutter. There is a reversal agent if they have digitalis toxicity. What was that reversal agent? Digibind. I don't know, for some reason it was easy for me to remember because I used to watch Digimon back in the day. It still slaps. It really does. They could have overdosed on beta blockers or calcium channel blockers, or they could just have them chronically prescribed and it just lowers their heart rate. What would a beta blocker do for me, Johnson? It'll lower my blood pressure. Very good. Okay. So it blocks the beta receptors in the heart, right? So the heart can't beat very fast and it can't beat very hard. So some of these patients actually may walk around with a bradycardia rhythm. This is why it's important to do a history, because it might initially freak you out. Hey, sir, why's your heart rate 45? I don't know. Better ask some more questions. Also, it may be a normal phenomenon for freaks that are well-conditioned, like athletes, like me, who are in superb shape, or patients who are sleeping. Their body just bradies them down. You want to see one? All right, bang. All right, tell me about it. Who wants to come to the board and do their steps? Thornton, let's do it. Come on, walk me through them.
We got rate of 40.
Y'all hear her?
There's a rate of 40 because we got 4 QRS complexes. There's a P wave for
How do you know that's a 6-second strip?
got the full lines.
All right. Bold of you to assume so.
There's a P wave for every QRS. There is, the P wave is within the parameters 0.12, 0.20. You have a QRS that is 0.8, so it's normal. You have a T wave. Yeah.
So everything's normal except what?
It's great.
Very good.
Yeah, I was about to say that's 3 seconds, and then there's. So yeah, the line to, from between line to line is 3 seconds. So you need, from that line to that line is 3 seconds.
Actually.
I was thinking that too, so I started counting like the big box on the side. That's.
Well, if you're in doubt, how many big boxes do you have to count? 30. So it's not quite 6 seconds. I did ask. I wonder if I set her up. Oh, bold of you to assume. I said that. Oh. All right, so what'd you learn? Be thorough, make sure. They could be. It could be. So the 5 questions answered again. What's the rate? Less than 60. Rhythm, regular. P wave, yes, yes. Is it rounded up right and pretty? PR interval's normal. QRS is normal. We've got sinus Brady. Yep. So significance of a sinus Brady, it can precede of AV block. It can precede asystole. What is asystole? What do you think there? Raph, tell me about it. Without systole. A without systole. So there's no cardiac activity produced on the baseline, on the isometric line. Why is that? They're dead. Cardiac cells have now lacked the ability to produce any electrical output. In a nutshell. So sinus Brady can precipitate escape rhythms or ventricular irritability. Also can be caused by a myocardial infarction, vagal stimulation, increased intracranial pressure. What would that be called? A Cushing's reflex. So they have a slow pulse, but the main thing we need to ask is what? Are they producing symptoms? What symptoms? How about altered mental status? Why would I have an altered mental status for a sinus Brady? Tell me about it. Not enough blood perfusion in the brain because cardiac output is what, Sloss? All right, so if my heart is beating slower and not as hard, the rate and the stroke volume, which is the amount of blood ejected from the left ventricle with each pump, is reduced. So would I see a patient's condition change? Possibly. Could I see a patient deteriorate rapidly? Absolutely. So this can cause altered mental status. Ischemic chest discomfort. Why are they ischemic, Martin? Lack of oxygen. Could cause acute heart failure and hypotension. So let's talk more about it. How do we deal with it? Maintain an open airway. Apply a cardiac monitor. But if you're coming from this school of thought, what do I want done? I want a 12 lead and a cardiac monitor put on within how long? Within 3 minutes. As soon as you meet the patient, because a cardiac EKG is part of your normal vital sign now. I don't care what your field ops tells you. I don't care what anybody says. It is a normal vital sign. I would like you to be the annoying paramedic that makes everybody do the right thing, even when they don't feel like it. That will be a, how do I put this? Sometimes standing up alone is the only way to go. And that will be, might mean you might have to irritate people because it's the right thing. Let's not skip steps. Let's not cut corners. Let's do the right thing every time because it's the right thing. Simply because on our honor, I don't want to skip a step for your family member. Let's not do it for somebody else. Is there an honor code to our job? Yeah. There's an unspoken honor code. And it is an honor to do this job. And it should be part of your honor code not to skip steps just because you want to be thorough. So worst case scenario, we can grab a line and throw some atropine on there. What type of drug is atropine? What do you think there? Stafford? I don't know you.
Atropine is. That's the entire lady, but I don't know.
Let's classify it as a parasympatholytic. So it's going to just bust up the effects of acetylcholine. So we have all day going on, right? Antagonism between parasympathetic and sympathetic. So if I get rid of that parasympathetic for a little while, what's that going to give dominance to? So what's that going to allow to happen? We're going to allow that rate to come up some. Atropine's got some other uses. Tell me about it. Organophosphate poisoning. It can dry secretions in intubation for a pediatric patient. That was good. I know. Oh, and I didn't even know it. Every now and then I do show it. Roll this morning. Thank you, Celsius. Good hands, people. All right, what's my dose though? What's the drug amount?
The entire pre-filled vial.
The entire pre-filled vial. Excellent. Excellent. We have made it dummy proof. We have made it to where it'd be hard to goof this up. But what if it's a pediatric? Ooh. Anybody use that Broslow tape or something? So the dose will be 1 milligram IV push, max of 3. Max of 3. Now, what if it doesn't work? We have a symptomatic bradycardia. You push the atropine. What if it don't work? But why would you choose between atropine or a heavier treatment? What would cause you to choose a drug, medicine versus Edison? What do you think there, Martin? They're alive or dead? Well, if they're dead, that's a cardiac arrest situation. They don't need atropine. They need faith healing. So
Somewhat conscious, still awake and alert. You don't want to go straight to the incredibly invasive or incredibly pain causing. Say, hey, this is gonna feel real uncomfortable, or it's gonna feel real weird.
absolutely. So that differentiation is made between you, the paramedic, between the patient's presentation and your clinical decision making. So what does that mean? Are they stable? Unstable. They've got symptoms, but are the symptoms killing them right now? So stable is, I'm just feeling a little weak. Their pulse is like 40, but the blood pressure is good. They're not having chest pain. They're not losing consciousness. They're not having trouble breathing. They're not having cardiac output showing problems. That's stable-ish. What if they're unstable? Blood pressure's dropped. They're having chest pain. They're having trouble breathing. They're pale, cool, clammy. And they're starting to lose consciousness because there's not blood to their brain. They're unstable. So stable patients can have some atropine. Unstable patients can have some transcutaneous pacing. Edison versus medicine. Now, the thing about with that, we have to remember, a lot of paramedic students think that no matter what, when you put pacing on, it's going to be a fix-all, but it doesn't connect. There's sometimes not electrical capture with every patient, which means you can put the pads on, turn it on, but the myocardium is so damaged that it doesn't have the ability to conduct or be excited enough to where you can start pacing the heart transcutaneously. So about, I'd say 45% of the time, pacing works. If it don't, we have to go to bigger, more invasive drugs. What you thinking, Baker? Well, answer it for me. You skank. And I want them. So the question is, if pacing's not working, what more invasive drug could I give to help the patient defeat this symptomatic bradycardia? Because my goal is to correct the disturbance and restore a stable perfusing rhythm. What drug could help me do that? Epi, is that a guess? You're telling me. It's not very confident telling me, but Epi. Put some bass in my voice. So epinephrine drip would be a good answer. So epinephrine drip 2 to 10 mics per minute, or a dopamine drip 5 to 20 mics per kg would be a good answer for that. So you would want one of those drugs to make the heart beat harder, faster, and to have alpha power, alpha receptor activation, agonism, to constrict that artery to raise the blood pressure. So if I raise the blood pressure, I can meet the perfusion needs of the brain, heart, lungs, and the rest of the body. So you would try pacing first. Again, that's actually your choice, really. It really is your choice. You know, dealer's choice. But pacing sometimes works, sometimes it don't. If you're going to use pacing, though, that is very invasive. You might want to think about giving it a little love. How about some Versed 2.5 to 5 milligrams to just ease the pain? Because it doesn't look very comfortable.
You're trying to pace them, did you say you probably pace them because blood pressure drop?
If they're hemodynamically unstable, so that's a good question. So if they're super unstable, you would skip all the IV, all the sedation, all the Versed stuff. But if they're, let's say they're in that middle lane, like they're between stable and unstable, they're not feeling great and they're starting to trend down. If I got the time to give somebody just a little bit of Versed to ease the pain, I will. If not, well, here's electricity. Sorry for your loss. So yes, we would have pacing being the option there. And then if that doesn't work, dopamine or epinephrine drip. That is a good mnemonic. That is a good mnemonic. You want to share that? So the mnemonic that John has that does work and stuff is A T drop eventually. So ATDE, all titties droop eventually. So that would be atropine, transcutaneous pacing, dopamine, and epi as a way to remember your kind of order of operation here. What you got? The amount you're going to give them is really just going to take the edge of pain off. You're not going to actually just knock them down. You would have to be careful though. If they have, if they got a hypotensive issue, you wouldn't give the Versed. You don't want to drop the pressure. But if they're in that middle lane where they're between stable and unstable, you would try it. Cautiously, of course. So all titties droop eventually. So atropine, transcutaneous pacing, dopamine, and epinephrine are your answers for that. What is pacing, by the way? What do you think there, Wrath? That was going to be your question? Well, let's talk about it. How about transcutaneous pacing is depolarize the myocardium? I force the heart to depolarize at the time frame I want it, at what I set it. So American Heart recommends about 70 to 80 beats per minute. You would start pacing at 20 milliamps, which is a small amount of electrical power versus the joules. If that helps you, think of joules as like a 45 pistol caliber. It's big. Think of milliamps like a 22. It's a lot smaller, less boom. So I'm going to force the myocardium to depolarize at the speed that I want. Hopefully, if I get capture, which means the electrical energy starts to hit and depolarizes the myocardium at the speed and rate that I want, the heart will respond by reacting to the stimuli. It'll cause ventricular depolarization, and it will be characterized by a wide QRS complex that is generated, and it is a artificial electrical depolarization that allows me to run the heart at the rate I want. Does that make sense? No? Good question. You'll see a big old spike, a straight line through the monitor. That is your electrical energy. That is your pacer spike. Now, as I adjust the electrical energy up, I'm actually going to chase down that rhythm. They have a QRS complex. I'm going to chase down that rhythm until that pacer spike slaps to the butt end of that QRS complex. And then you'll see a change happen. You'll see electrical capture where on the monitor, you'll see the rate go to about 70 or 80, and it'll be a big, wide ventricular paced rhythm. That's when you know you got electrical capture, but you can't trust it. You have to go back and confirm I've got mechanical capture. Does the rate on the monitor match the rate that the heart's actually beating at? So now I need to confirm with mechanical capture. If we got time today, I'll show you what it looks like on the cardiac monitor. I am electrocuting them, yes.
So I would pace them going during the RS interval, or not the RS interval, PR interval.
We're going to jump right into that PR interval and pace them right at the beginning of where their ventricles depolarizing at. And I'm going to take over that depolarization with a stronger stimuli. And hopefully, if it captures, I can run the heart at a rate that is more conducive with maintaining life functions. I hope. I hope. So again, we'll start at 20 milliamps and we'll run that bad boy up to as high as we need to get the rate of 70 to 80, because that's what will maintain life functions. How we feeling? So the SA node can produce rhythms that are too slow. It can also produce rhythms that are too fast. Let's talk about it. So we learned that sinus Brady is perfect, except the rate. Sinus tach is the same thing. All the parameters are within normal limits, except the rate. The rate will be over 100 beats a minute. Anything over 100 beats has got a last name of tachycardia. So is it sinus tachycardia, though? We have to determine that based on if there is a perfect and pretty P wave. Is the impulse originating from the SA node, or is it coming from some other type of atrial dysarrhythmia? So tachycardia means fast heart rate. Only difference is the rate. Are you picking that up? The sinus rhythms are the easier of all of them, I feel, because they're really just perfect except for rate. Now, what can actually cause sinus tachycardia? Because the rate for sinus tach can run from 100 to 150 pretty quickly. Exercise, fear, stress, anxiety, ingestion of stimulants, coffee, crack, Celsius, monsters, bangs. Everybody's got their flavor. You mentioned that earlier. You mentioned that student earlier from Nines. He had an addiction to Bang Energies, and I watched him drink 3 or 4 a day. At this point, I don't think they work anymore. It's more for the flavor. So what will be the problem with having a heart rate that fast?
You're not getting as much blood.
Okay, I may not have the ability to refill the ventricles. High cardiac oxygen demand. It could put the patient into a chest pain or a MI situation. It could also result in hypovolemia, CHF, severe hydration, or acute MI. These are things I want to avoid. Work smarter, not harder. Also, again, the body does this initially in a shock response. It also does this in response to fear, stress, anxiety. And sometimes it may be just that simple. You get on scene and the patient's stressed out. Like, who wants to call 911 and look at y'all at 3 in the morning? Most people don't. Like, the average person does not want to look at you, does not want to call 911. That's fair. That's extremely fair. But if they did call, think about the average adult person, like, let's say one of your loved ones called. Are they just going to call for the hell of it? No, they were scared. They were freaking out. They may not have had the ability to navigate the situation they're in, or they didn't understand it enough to where you could simply provide instructions and reassurance and put that issue for them to bed, and then they can go to bed, and then you can go to bed. I promise you it's faster a lot of times to run the call and get it over with and sit there and complain about trying to get a refusal. That's a proven thing. I promise you. Just run the call, be done. I can't stand people sitting on scene 30 minutes trying to get a refusal. Just run it. I'd have been at the hospital, dropped off, and done by now. Back at the station. I'm good. What? What video? Oh, yeah, that one. I'll show that to them later when we hit behavioral health. But you've already seen it, so you know that type of negligence was unwarranted, unneeded, and completely preventable. So how do I identify sinus tach? Wrath, tell me my 5 steps. You said heart rate, rhythm. What about the P wave?
Yeah, the P wave and then the P wave.
Rate, rhythm, P wave, PRNO, QRS. So I'm asking this rhythm 5 questions. What is the rate? 100 to 160. Rhythm, it's regular in the atrial sense. It's regular in the ventricular sense. Is there P waves of 4 of them? Yes. Are they rounding up right? Yes. PR interval length is Normal, 3 to 5 blocks, 12 to 20. QRS complexes, do they all look alike? Are they less than 12? Everything's perfect except the rate. Rate. So again, there's the 5 questions asked again. And you'll notice for a faster rhythm, at a quick glance that the spiky things are close to each other. QRS complexes occur more frequently. So what is the significance of a tachyarrhythmia? It could be compensatory. It could be a shock response. It could be from a fever. It could be due to heart failure. Why is it dangerous in acute myocardial infarction, Chamberlain?
So the heart's probably not beating in the block, already because of the block.
Very good. Very good. So in a AMI situation or a chest pain patient, tachycardia can cause an AMI to extend and be worse and damage more tissue more quickly. This is why I don't understand why some medics they just do the nitro, but why are you not doing the fentanyl to take the pain away? It's part of your monofona protocol. Take pain away, anxiety goes down, heart rate goes down, the AMI will not extend. That's easily understandable, right? Everybody's kind of picked that up. But how many of y'all are seeing medics actually give pain meds for chest pains? You're not seeing it? Why? I just explained the reasoning. Does it make sense to you? I mean, does my reasoning for giving pain meds make sense to you? Okay. Then why are we not doing it? I'm going to call somebody out real quick, not by name, but by company. Some engine company that resides in the city of Atlanta. I get there and I ask this question, hey, why didn't you give me anything? Not even nitro. And dude's like, well, it's a lot more paperwork for me to give it. And I'm like, and it's none for me to give it, right? I don't have to do paperwork. I do have to do paperwork. And you waited 20 minutes for me because we were level 0 and I was at North Side Atlanta, which is up past Buckhead, and you're down here at what's that place? The one with churches, the Kroger and the Church's Chicken.
Oh, there's RDA on Cascade.
Cascade RDA. So it was you. Trash.
Blame staff.
Look at his hat.
So other clinical pictures, you could have a rapid regular pulse. The patient could be asymptomatic. They could not have anything on it. It could just be a issue. Was I done chewing on that? I don't know if I was done chewing on that, but I think you get my point, so that's enough. I don't think complaining to you about it will do anything now. That was years ago, but if I can prevent it from happening again, with you being the future of paramedicine, that's my stance on it. Feel free to defend why you wouldn't give your patient pain meds if it can stop the infarct from getting bigger and lower the heart's oxygen demand and relax them a little bit. Nope, I'm done now. Okay. All right, so let's take a look. Who wants to? Martin, come see me. To the board, sir. Ding, 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 ding. Oh crap! Go back. Ding, 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 ding. All right. Walk me through your 5 steps here. You already know it's sinus tach. I got a giant sign on the board. How would you determine it's sinus tach?
You look at heart rate.
You do realize that eventually I won't breadcrumb and there will just be a rhythm up there, right?
Oh yeah.
Okay.
So you look at heart rate, and this is going to be 1, 2, 3, 4, 5, 6, 7, 8, 14, 140.
Hell yeah.
So definitely size tag. Look at my rhythm. Rhythms look the same.
How do you know? How do you know they're the same distance apart?
Oh, you measure.
How would you measure them?
QRS.
You're not doing it. You're just telling me you're doing it. What's something you could use on scene, like EKG paper or any paper? Or calipers if you're cool enough to have some. Only me and Whitworth have them because we're only cool people in here.
So mark it here.
All right, use it, mark it, then march it. Mark it, then march it. What does it mean to march it? You walk it out.
Look at my P waves, which I don't really have a.
You do have P waves,
Very.
but what do you have occurring there? You have partial fusion. You see where the P waves about to go away? So the rate's 140. There you go. SVT is an umbrella term. junctional tach, sinus tach, atrial tach, whatever tach it is, at a certain speed, fusion occurs and everything becomes SVT. Because you lose the P wave. You lose every other identifying characteristic that exists. SVT is an umbrella term. So here in a minute, you're going to see actual fusion and that P wave goes away. But right now I can see it. So the criteria is if I got everything's perfect except the rate, it's a sinus tach. Keep going. You're doing great.
We want to measure the QRS complex,
Okay.
but same thing, except calipers and for fancy, just piece of paper. Markets, they're the same.
All right. They're all the same. They're less than 3 blocks wide.
Heart rate rhythm, QR interval.
So what's a normal PR interval? Well, I got you.
0.12.
Okay. 0.12 to 0.20. How many blocks is that?
It's going to be about 3 blocks.
3 to 5. Very good. 3 to 5. So QRS complex, we're going to measure how wide it is. Hell yeah. Show. So how wide is it?
A block.
All right. Is that less than 3?
A block.
So everything's normal except the rate. Do you have to treat this?
Depends.
Only if what?
Symptomatic.
Describe some symptoms to me, everybody. You can go, Martin. Thank you. You did good. We're saying altered mental status. What else? Chest pain. Why would I have chest pain? My heart's overworking. That's got a supply demand issue. Why would I have hypotension? Because I don't have filling pressure, so I'm going too fast. Why would I have a altered mental status? I don't have blood to my brain. Why would I have trouble breathing? My lungs don't have blood flow. I don't have to get too spicy with this if it's. I don't have to get aggressive with this unless it's showing symptoms. What if I wanted to slow it down though? What options would I have for a too fast heart rate?
Calm the person down.
Okay. That works all the time. Calm down. You ever told your wife to calm down? How'd that go for you? You're acting a little crazy, babe. How'd that go for you?
That's what I mean, but.
Oh, that's not what you meant? Let me go ahead and set you up for a couch night.
Just like you.
Oh, okay. He probably knows very well. Jokes on you. I sleep on the couch all the time. I like it. All right. So myocardial oxygen demand will increase. It can precipitate an MI. It can cause an MI. Why? The demand is more than the supply. And if heart muscle don't get blood flow and oxygen, heart muscle starts to die. Find the cause, treat the cause. You fix the rate, a lot of those other problems will go away. A lot of those other problems will go away. Like what? Can a sinus tach be fast enough to where it requires aggressive intervention? Yes. So you have options: vagal maneuvers, adenosine, that's medicine. Then you have Edison, which is a synchronized cardioversion. A defibrillation is like an atom bomb going off. It's going to hit everything. A synchronized cardioversion is more of a sniper round, where it's a very precise hit. And you know what? I'm going to show you how to do that. So a sinus dysarrhythmia. It's the same as a normal sinus rhythm with slight irregularity of the heart rhythm. Slight irregularity of the heart rhythm, which means it'll have normal, then an irregular R to R interval that changes with respirations. Why? That's mainly common in kids and young adults. Why? They don't have developed chest walls yet. So that pressure in the chest is hyper-resonating. That air in the chest can cause the heart to be put under more pressure, and it will cause an arrhythmia, which is, again, it'll cause kind of a skipped beat. And it gets worse if they start having inspiration, expiration issues. Now, how do I tell it apart? This is known as a sinus dysrhythmia or a sinus arrhythmia. It's based on respiration. It's a patient with a normal sinus rhythm that has what? An irregular R to R occasionally. So how do I know it's a difference? How do I know it's irregular? Well, you have to be using your tools like your calipers to make sure that the rhythm is actually farther off. What you got? Yes, very much so. It'll throw their very young asthmatic patients. It could happen to them as well. Because again, that air pressure in the chest, they've got air trapping as it is. The compression of the great vessels in the heart, it will cause them to have a sinus dysrhythmia where they've got a normal sinus or a sinus tach, and they have irregularities created by that air pressure in the chest. Make sense? Lovely. So how do I know that it's irregular? Well, we told you there is a bit of a little leeway for regularity. If it's 0.06 or less, it's normal. But 0.8 apart, indicating that it's irregular. How many blocks is that? 2. So if there's a difference in 2 blocks, it's irregular. Go ahead.
Yeah, that should be 0.0. That's 20 times 3.
Okay, it should be 0.08, whatever. You know what I mean? 2 blocks. Shut up. You know. I'm too drunk to taste this chicken. So causes could be what? Sick sinus syndrome, certain drugs, digitalis, somebody that's on a long-term beta blocker for an adult to have it. Again, it's very common in kids. You dig? So how do I ask the questions to identify a sinus arrhythmia / sinus dysrhythmia? Again, everything's normal except what? There is a variance. A variance that is located where? The regularity. The rates, 60 to 100. Everything's perfect. P wave's perfect. PRN was perfect. QRS is perfect. But what is not perfect is it has an irregular R to R interval that you will have to find out. Who do I want? Who would be the most miserable up here? He's not here. Huh? What are you doing? Come tell me the 5 steps here. Don't make eye contact. I want you to come and do your 5 steps on the board. All right, walk me through your steps and use a tone loud enough for my viewers at home to pick up.
Okay. We're gonna look at the heart rate.
Can y'all hear her?
Barely.
Barely. Whose side are you on? She'll remember this.
The heart rate, you got 9. So it's 90 beats per minute.
Okay. It's just us hanging out. Thought we were friends.
Okay, rhythm. Don't worry, mark this paper. So what is it? You don't want?
You lower the screen.
Nope.
No.
You want a stool? So everybody at home can see this. Yes, it is.
So that's a lot. One. We go so far because they're all the same.
They're all the same? Are you sure?
No.
You're positive they're all the same?
No. Rhythm. Okay, on the table. Help yourself. There you go.
There's a little swivel thing on the front. Look at that.
I was gonna struggle.
I was gonna let you struggle.
Do that.
Strength is a product of struggle.
There you go. That should be.
There, you can probably reach that one now. Look at that.
Okay.
All right, step 1, we got the rate being at 90. Step 2, we have to find a R to R variability. What is the variability? Oh, they're not the same distance apart.
So rhythm is irregular.
All right, so what's the next step?
Okay, so now we gotta look at the P. Is that round? Is it pointed? I don't know. Oh, it's pointed. No, it is round.
You tell me.
So.
Is it coming from the SA node? Do they all look the same? Are they rounded and upright and normal looking?
No.
They are.
They are?
They are.
Well,
It ain't always got to form a perfect round hump. It's close enough. And
okay, and the intervals is it's 3 or less.
okay. PR intervals 3 to 5 blocks. Is that not? Is that right?
Yeah. 5.
Okay.
This is irregular. It's 2. That's 1. That's 1 half.
All right. So what's next?
I mean, we already did the P.
You did the P wave, PR interval.
QR.
All right. Is that less than 3 blocks?
Yes.
All right. So everything's perfect normal except for one irregular R to R interval. What does that mean? We have a sinus dysarrhythmia. Sinus dysarrhythmia. Good job.
Oh, you want
You, the rest of them can't see good. All right. So again, common in adults and children could result in a irregular pulse, but it rarely produces symptoms that you have to do anything about it. Rarely does it produce symptoms where you actually have to get busy with it. Now, what about a sinus arrest? What does it mean for an arrest to occur? It'll be all right. Just leave it alone. It'll come back. It'll come back. See, it's back. All right. So a sinus arrest. We have sinus pauses. We have sinus arrhythmias. We have sinus arrests. So a sinus pause will be a whole missed, dropped QRS complex because the SA node failed to initiate an impulse. So a sinus arrest could be several missing complexes. Several missing complexes. The entire PQRST is gone. It caused a slight period of cardiac standstill. They have a period of asystole. And this is going to go on until that SA node decides to get his butt back to work. What do you think could cause some of that? Ooh, that's a good one. Electrolyte imbalance is great. What else? Hypoxia. That SA node needs to be fed blood and with oxygen in it. If he ain't getting it, he's gonna be pissed. I don't know about you, but if they didn't pay me to come here and look at y'all, I wouldn't work. I'm just telling you. If you weren't paid to go do your 24, 48-hour shift, whatever you're doing, you probably wouldn't show up all the time, would you? Eventually, you'd stop showing up. So the SA node is paid in blood flow that is rich in oxygen. You don't pay him, he don't come to work. That makes sense? Absolutely. Other causes could be what? SA nodal disease. What's that? What'd you say? Tamponade? I'm not going to say never, but it's not something I've listed or thought of that would cause tamponade would normally cause a bradycardia or a arrest in my experience. How about SA nodal disease or certain drugs such as digitalis or salictates? What's that? Aspirin overdose? Aspirin can do it. It could also occur as a result of an MI. Why? What's happening during an MI? If that right coronary artery is knocked out, that tissue will die. And again, you don't pay the SA node, he don't come to work. So these occurrences are infrequent. Patient assessment's imperative. What does that mean? Imperative. Thornton, tell me about it. Your assessment is going to be imperative to find out the who, the what, the when, the why. You fix the underlying cause. Most likely, you can fix this patient from having sinus arrest problems. What kind of problem could present with a sinus arrest where you have several missed beats? How about bradycardia? Symptomatic bradycardia created by sinus arrests. If you've got 2 or 3 missing beats in 60 seconds, your heart's going to be missing quite a lot, right? So the heart rate could drop to a point where it is not sustainable for life. Something to think about. Something to think about. So questions we've asked. What is the rate? It is variable depending on the frequency of the sinus arrest. The rhythm is irregular, but the P wave, the PR interval, and the QRS are all perfect. Who do I want? How about we just, I'll take this one on the nose. We'll just stay where we're at. All right, so we see that we have a rate that is variable. So 1, 2, 3, 4, 5, 6. 60 is the rate. Not too bad, right? Then we got the regularity. It's irregular. We got the P wave. It does exist. PR interval is normal. QRS is normal. Everything's normal except that big pause area right there. Why is there a pause? SA node ain't coming to work. So that is an issue only when we are encountering patients who have missed enough beats to where they have that go on. How about a rate of 30? Because you got 3 or 4 missed beats. Would that be a problem? Absolutely. So what if the patient's pretty asymptomatic? They don't really have any problems. They're medically stable. What do you do about it? You don't have to do anything. Observation, observe and report. Watch them for deterioration. But if there is bradycardia or symptomatic issues and they're medically unstable, you got options: IV drug therapy or transcutaneous pacing. IV drug therapy or pacing. These are your options. All right, a sinus block. SA node fires on time, impulse is blocked before it exits the sinus node. Something's blocking it. Could be ischemia of the SA node, digitalis, excessive vagotone, or degenerative fibrotic disease. Could be an issue. So one every now and then ain't gonna cause any problem, but frequent prolonged episodes will compromise cardiac output, will cause a reduction in the amount of blood that the heart's putting out in a minute. Could result in syncope, poor perfusion, all the signs of medically unstable patients. What do I do if I got poor perfusion and I got a patient that's exhibiting bradycardia due to sinus blocks or sinus arrests? Well, the answer is you can try drugs like atropine. But again, if it's blocked, is that going to help? So what do I need to do? Something to take over. Let's talk about pacing. You could try for pacing. If that don't work, we can try a dopamine drip or an epi drip. What's my dose for epi drip? Baker. Okay, so my epi drip dose is going to be 1 to 1,000, 1 milligram in a 250 bag, 60 drop set gives me 4 mics a minute. I like it. But what's my dose on paper for an epi drip? Between what and what? 2 to 10 mics per minute. 2 to 10 mics per minute. So if you wanted to get 4 mics, start them off there. Again, 1 milligram, 1 to 1,000, 250 bag, 60 drop set. That'll put you around 4 mics a minute. I'll teach y'all the clock method, which is a method for how many drops a minute you'll need to reach that. But yeah, it'd be pretty close, even fully done like that, which is it's a good indicator to, even though you've got this set, I'd watch the patient. I don't want their ears turning red, you know. I don't want their blood pressure running 140 over 90. So I'm just looking for a systolic of 90 or a MAP of 65. I'm just looking to keep them alive long enough for them to do what they're going to do in the ER, basically.
You want to start at 2 and increase it to 10?
You can always give more, but you can't take it out once you put it in. So I like to work in steps. For something so aggressive, like we're doing a epi or a dopamine drip, I like to start low and move up, because I would like to provide. I just want to hit that therapeutic window. Remember we talked about therapeutic window? We got this little small window where I'm going to get the desired effect I want. I give too much, I put the patient in toxicity. I don't give enough, I don't get the desired effect I want. So I'm going to just increment it up till I get the desired effect I want, which is a blood pressure of 90 systolic, MAP of 65, heart rate of 60 to 100. So I'd be very carefully monitoring and watching that patient. What about sick sinus syndrome, SSS? So sick sinus syndrome is not really an arrhythmia per se, but it is a combination of arrhythmias, sinus node disease, or ischemic tissue. Again, the heart ain't getting enough blood flow. It's going to cause the SA node to act drunk. What does that mean? We're going to have wild swings in heart rate. You know what? I'm going to be tachycardic for a minute. Hee hee. All right, I'm tired. I'm going to go slow now. Oh, sinus Brady. Back to normal sinus. Wow. So basically, the sick sinus syndrome is the SA node is upset. It is irritated. It is sick. It could be nodal disease, could be ischemia, could be digitalis. You notice digitalis cause a lot of problems, right? In most of these slides, you'll see digitalis being one of the big problems. So sick sinus syndrome is where you have a alternating pattern of bradycardia and tachycardia, back and forth, back and forth, back and forth. So over time, your body will, a lot of people, their body will develop a toxicity to the digitalis. So over time, they might build up a cumulative drug effect because they couldn't excrete all of it. So they could build up a cumulative effect, and that caused the digitalis toxicity. And it could cause what we call a did sag in the EKG, where you see that part of the EKG sag down, and it kind of looks like a mustache curl. It looks like a mustache curl, so we call it the mustache curl. But it's a very, very like obvious sign, and I got pictures coming, so we're not just theoretically talking about it. What? Purple foxglove, yeah. You could actually. So like a lot of times when you're when we talk about wilderness medicine, which I think is important because who knows if you go camping or hiking or if the zombie apocalypse happens, whatever. But when we talk about a lot of these medications, they have natural origins. So this one has a plant origin, and a lot of like medicine men, Native American shaman, whatever, they were using flowers and plants to get desired effects. It would still be very possible to cause a toxicity from eating the flower, yes. And again, like we talk about aspirin coming from the bark of a willow tree, it was still something that could cause a toxicity in high amounts and over time. And, charcoal, it's unrefined, form, just charcoal, not activated charcoal. Charcoal can go through the GI tract and absorb certain poisons and medications and stops you from dying from the poison, inoculating a lot of the effects it would have. So a lot of the stuff we're doing now that seems like fancy medicine really came from a lot of our forebears who were brave enough to try some stuff. Like I love mushrooms. Somebody had to find out which ones were safe to eat. So let's pour one out for the homies that you did it for, They didn't make it. That makes sense? I like it. Oh, yeah. So give me a quick cheat sheet here. Sinus rhythms all originate from the SA node. Major difference for them will be rate or rhythm. Everything else is going to be perfect. It'll be the rate or the rhythm that identifies it. It'll always have a perfect, pretty P wave. Perfect, pretty P wave. Perfect, pretty P wave. So a cheat sheet for you. You ready? Normal sinus has all that. Sinus Brady's that, except slower. Sinus tac's that, except faster. Arrhythmias are what? They're normal, bradycardic, or tachycardic. They could be irregular. What arrhythmia? Sinus arrhythmia is what? A missing or irregular R to R. A regular R to R interval possibly caused by air trapping. What about a sinus arrest? Sinus arrest is brought on by SA node not firing off. A sinus pause is different than an arrest. An arrest will be several missing beats, while a sinus pause will be a one missed beat.
Would it still be at that point?
Why?
pause still be at that 0.08,
Say that again.
there's a difference between the pause and the rest.
Okay, you're getting confused. Let me clear it up. So that 0.08 difference in R to R interval, that would account for the sinus arrhythmia or dysarrhythmia. So the sinus pause or arrest will be an entire missed beat, like the whole PQRST is gone. So a pause is there's a one missing. An arrest is there's 2 or 3 missing. You dig? That's how you tell the difference.
What, is there a discernible difference between the sinus pause or arrest and sinus block on? If you're not getting.
All right, we talk about now atrial rhythms. So origination of an impulse is based upon who's pacing the heart most of the time. We have a line of succession. The atria itself wants to survive. The body is a very smart organism where it has compensatory mechanisms. If the SA node fails to produce an impulse, there are compensatory mechanisms from the other pacemaker sites that will try and attempt to kick in and pace the heart. These rhythms are classified by the heart structure where they are originating from. So it is originating from the atria, but it is not from the SA node, you dig? So whenever the SA node fails to generate an impulse, atrial tissues or even intranodal pathways may generate an impulse. Everybody with me so far? Lovely. These are atrial dysarrhythmias. What does it mean for something to be a dysarrhythmia? Abnormal, painful, difficult, not cool. Rhythms not considered life-threatening or lethal. They must provide continuous assessment. So these rhythms can occur and they may or may not be life-threatening or damaging. It depends on how they present with the patient. AFib, for example, there's millions of people that walk around with it. Doesn't mean it's life-threatening unless it becomes AFib with RVR or rapid ventricular response. Or if it's an acute AFib that over time the patient doesn't get seen about, so they don't get put on blood thinners, because what happens if the ventricle, the atrias are not pumping? They're going to quiver. They're going to have clots form. There's a lot of questions on registry about clot formation and atrial fibrillation causing strokes, heart attacks, and PEs. So let's talk about them. We have a wandering atrial pacemaker, or a WAP. We have multifocal atrial tachycardia, or MAT. Premature atrial contractions, which is a PAC. Paroxysmal supraventricular tachycardia, supraventricular tachycardia, atrial flutter, atrial fib. These are atrial rhythms. They originate in the atria, but not within or from the SA node. Let's talk about it. A wandering atrial pacemaker occurs when the pacemaker site literally wanders or travels from the SA node to other pacemaker sites within the atria. It is literally what its name sounds like. It's a wandering pacemaker. The SA node can still remain the dominant pacemaker, but you'll know a WAP by its appearance, its morphology of the P wave. How do I know that? In your interpretation, you will notice that there are at least 3 different P wave morphologies. At least 3 different P wave morphologies. The size and shape will vary based on the site of origin. They may appear upright, inverted, or absent. So, in a nutshell, the rate will be between 60 and 100. The rhythm could be slightly irregular based on the origination site of the P wave, and it will vary in shape. How often, how much, and how much morphology changes we see, that's variable. Because literally, that wandering site is literally wandering all over. So, how many morphologies do we need to consider the WAP? 3. There we go. So usually 60 to 100 might be slightly irregular. The change in the P wave will be size, shape, and location. And the length of the PR interval is going to be variable depending on who and what and when what atrial pacemaker sites jumps in. But you will have normal looking QRS complexes. That doesn't usually affect them. You want to see one? Hell yeah, you do. I got a better one. Hang on. Ready? Do. A whop. So we have 3 different P wave morphologies. Looking at there, we have a normal, slightly peaked one, a missing one, a slightly humped smaller one, and then we have a whole normal looking one at the very end. So what happens though when we have a WAP? Do I have to treat it? I can note it, observe, and report. If it's not causing them any symptoms or damage or problems, I do not have to bother with it. I don't have to bother it if it ain't bothering them. It's one of the things you're going to need just to notice.
So like, say for example, they just happen to see this, so we need to take them to the hospital for this, or is it something like, hey, you could probably see your primary care.
So is it, if it's news to them that they have some kind of cardiac abnormality, the appearance of a WAP or a multifocal atrial, a wandering atrial pacemaker, it has an origin story of why it's happening. Then we need to find the root before it becomes a problem. I would suggest let's go get you looked at right now. 1, to get them help and care now, but 2, to absolve myself of any liability in case I leave and this thing turns into a MAT. Now, a MAT is a WAP that goes 100 miles an hour. So a multifocal atrial tachycardia is when there is 3 different P waves, but it's just going 100 miles an hour. It's over 100. Its last name is tachycardia because it's over 100 beats a minute. So it's a wandering atrial pacemaker. It's a variant of it, but it's just faster. Yes. I'd probably say, I don't want to say no because anything's possible. In my experience, no, though. Usually if it's after, it's either a non-conducted beat where it sent a signal and the AV node just stopped it, but you can see the atria did depolarize. It could have a connotation of a flutter wave, or it could have a issue with it being a slower wandering atrial pacemaker that may have also some second degree type 2 blockage in it too, which means that there's going to be a lot of P waves there's no QRS behind them. So that sounds like there'd be a lot going on there. But when we talk about synchronicity of the atria, are they the same distance apart? Because we have, with a 3rd degree, part of the problem is that the atria and the ventricles aren't talking to each other. So you can march out the P waves, they're perfect. You can march out the QRSs, they're perfect, but they're not in sync. So that's another possibility as well, if there is a complete or mostal partial block there. So a MAT, or multifocal atrial tachycardia, occurs when a WAP gets over 100 miles an hour, and it could happen in chronic pulmonary disease, toxin of digoxin, electrolyte imbalances. So if they got this going on, there's probably a reason, and we need to get them looked at. You want to see one? Ooh, look, a dead body. So let's take a look. We got a big old spiky P wave. Spiky P wave. There's a little one. There's a mid-sized one. Big spiky P wave. There's a round one. That one looks good. Hey, Roundy. So we got a couple things going on here, right? Another example of the MAT. So break down for me, Martin, what a WAP is.
Just when the
All right, I like it. I like it. Tell me what 6 sinus syndrome is. Sloss?
Sinus syndrome is alternating Brady tachy rhythm.
Okay, wild swings in heart rate. Oh, tell me about a sinus pause there, Baker.
When you're showing them,
Hmm.
they're showing Tuesday, you have a call.
I like where your head's at, but let's do this. Sinus pause would be when the SA node fails to initiate an impulse. So we have a, yeah. Say it better then. We failed to initiate an impulse, so we have a drop beat somewhere. What about a sinus arrest there, Tyler?
This is the whole rhythm.
A whole couple complexes, right? A couple PQRSTs are missing, right? That's the problem. What about sinus arrhythmia, Shitworth? Oh, crap. Or is it a slight irregularity in the distance between R to R intervals based on pressure in the chest? Yes. All right, let's talk about Pac-Man. You ready? Okay.
Is the tachycardia part of? Is it a wandering atrial pacemaker and then the person also has a fast heart rate, or is the tachycardia part of the pathophysiology?
It would be variable based on the underlying reason why they developed the WAP.
For example, if somebody just had a WAP going on and then they were a bystander in a shooting, so their heart rate's fast, would that count?
Still counts.
Mistake it for tachycardia.
I don't think we're mistaking it. Like they've got a WAP and then they're tachycardic. So it's going to present as a MAT.
Okay, yeah, I guess I just was asking, I guess, whether this disease process will cause them to become tachycardia or if that is just separate.
Both are possible. And again, it'll just be a wandering atrial pacemaker. I got you, Whitworth. Give me 1 second. I don't want you to hold your hand up and get tired. It'd be funny, but if some kind of stressor is introduced into their body and life, their body will respond by jumping up the heart rate. So I can't label it a wandering atrial pacemaker anymore if it's still if it's 100 miles an hour. So it would change what it is, but it could be secondary to, extrinsic stressor. Yeah. Good question. All right, Whitworth.
I was just trying to see on the script, you did earlier, how long been like, where to walk with us.
Oh, you missed it. You weren't here. So a wandering atrial pacemaker.
I see it
How you do?
now. Yeah, I do.
Cool. So again, it's going to be 60 to 100 rate, but it's going to have 3 different P waves in a 6-second strip. And a MAT, multifocal atrial tachycardia, is simply a wandering atrial pacemaker that runs 100 miles an hour. Multifocal meaning that there's foci points. There's many points of area that have that enhanced automaticity that are trying to pace the heart and take over. They're trying to run the show, and they all get a chance to try. SA node's still the dominant pacemaker, but it's bouncing around. We go back 1 or 2. We can see in the heart area up here that these little stars that are hard to see right here along that intranodal pathway are all trying to produce depolarization. And those little pacemaker sites are producing depolarization of the atria, and they're just taking turns. So that's the problem with this rhythm here. Again, if it ain't hurting them, don't mess with it. All right, PACs. A PAC is an incomplete or non-compensatory pause that often follows a PAC. So looks like a normal complex of the underlying rhythm, but it is normally due to being premature. So what does that look like? We have regular R to R intervals, and then we have 1 or so or more that isn't arriving early. It's premature. It arrives early. Way earlier than expected. What does that look like? Let's talk about it. So the rate's usually pretty normal. It can go up, but it's usually normal. It can be faster, can be slower. The rhythm is usually regular except for a PAC, a premature atrial complex. What does it mean to arrive prematurely? Sloss, you're the expert. Tell us about it.
I know about
That's what I would say too. But if you knew anything about it, what would it mean to arrive prematurely?
that's where, you leave the house early so you get to work early.
Way sooner than expected, right?
Then you very soon.
And everybody's disappointed. Correct.
But one person
Usually. Should be two.
usually.
He's not mad though.
Hey, I got mine.
We were racing. I won. Rubbin's racing. Give them hell, boys. All right, so the rate's normal. It will be irregular. It'll be regular except for the PAC. Now, the P wave before each QRS, they'll all look the same except for the premature complex that arrived early. PR interval could be variable depending on the pacemaker site, and the QRS is normally normal. So let's talk about it. Everything's normal except there is an early complex showing irregularity. You want to see one? Let's do it. All right, so what we have here is these guys are about the same length apart. Let's do it. Boop, boop, boop. Oh, this guy's kind of came a little bit early. Boop. So we have this fellow here causing all the drama. We see that? Everybody saw that? So what do we have here? We have a different looking little P wave, and it's hard to see from where you're at, I know. A different looking little P wave that caused this complex to arrive early. Now, these things can occur sequentially in pairs. They can occur every other beat, which is called bigeminy, and they can also cause every third beat, which is called atrial trigeminy. Remember we talked about the rhythm being regular or not? Occasionally irregular means there's a PAC every now and then. If there's two in a row, that's called a pair or a couplet. If me and you together, Martin, we a couple, right? Hell yeah. So this is called a couplet. Now, if it occurs every other beat, that is atrial bigeminy. Bi means two. Ain't that right, John? Yep. Go watch New Girl. I'm not judging. Okay, go ahead.
So the only difference, so in this case, the premature P wave is now look different than the rest of them.
Yes, this
So
one.
that would be the only difference between this, assuming the rate is normal, that would be the only difference between this and sinus arrhythmia. Because the P wave is gonna be different.
Yes. So with sinus, that's a good question, actually. I'm glad you said it. So with a sinus arrhythmia, you still see the pretty beautiful little rounded upright P wave, but with a PAC, it'll be an arrived early beat. Now, you know that because it's closer to this. All right. But also with this, if you're doing all your 5 steps, you'll notice that one of these P waves looks different. This one's actually pretty similar, only slightly different. Most of the time, a PAC is actually grossly different. Like I said, a round to be pointed or upside down or weird looking. So what we see here in the heart portion is that this is the SA node producing these guys. And this PAC came from another ectopic foci over here, right below it. So it'll look different because the origin site's different. So, all right. So let's say you got a brother, all right? Y'all got the same mama, different daddies. You look similar, but slightly different, right? Happens, right? You look similar. You look a little different too. So that's what we got. So if it happens every other beat, what's it called? All right. Sequentially in pairs. Atrial couplets. Every third beat. Atrial trigeminy. Every fourth beat. Every fifth beat. Nope, no such term. No term. It's just an occasional PAC then. And there's your memory. So why would you throw a PAC? For the fun of it? Hell yeah. Okay, ischemia is going to be across the board, everybody. What about stimulants, caffeine, alcohol, hypoxia, increased sympathetic tone, electrolyte digitalis toxicity? Cocaine can do it. Hell yeah. I want you to remember this term also. When any premature beat occurs more than 6 times per minute, it's termed frequent. So let's say patients showing a sinus rhythm of 80 beats per minute with frequent PACs, which means you can't lock it into the bigeminy, trigeminy, quadgeminy area, but they have it pretty often where it's frequent. What if it's less than 6 times a minute? It's termed occasional. Patients showing a sinus rhythm, not normal sinus, because is it normal to have PACs? It's no longer normal sinus, but it still is a sinus rhythm. Underlying rhythm is sinus. PACs, PVCs, PJCs, these are not the underlying rhythm. It is in addition to. So sinus rhythm at a rate of 80, patient has occasional PACs, which means they have probably one every 5th, 6th, 7th, 8th beat. But what if they have them in pairs? Atrial couplets. Patient has a sinus rhythm with atrial bigeminy. What did I just say? Everything's normal except every other beat is a PAC. Now, learning to speak this language will not happen overnight, so don't beat yourself up if it's like, what? What do I do with my hands? I'm freaking out, man. Frequent.
More than 6 times.
Yeah. Something like that. You know what I meant. Yeah. I like it. All right, so that's the PACs. Now, what about reentrant dysarrhythmias? We spoke about the short circuiting of the conduction system and the unidirectional block that occurs. So this develops when an electrical impulse is delayed or it's blocked in a area. So it reactivates the myocardial tissue for a second and subsequent time by the same impulse. So it's the same electrical impulse. It's like, I'm not going to throw that. It's like me and John throwing squishy back and forth. We're going to just keep throwing it back and forth. What it's supposed to do is I'm supposed to throw it to Wrath, who moves out the way. Yeah, I can see you now that he ain't here. The obvious. So what's happening is we're just throwing this back and forth faster and faster and faster, but we've blocked off Davide here. We're supposed to be throwing it around the room, but it's just me and him throwing it back and forth faster and faster. Does that make sense? We're reactivating the same myocardial tissue with the same impulse. Once we have generated an impulse and threw it down the line, you should be gotten rid of this one. I should generate a new one, but it's the same one. Is everybody kind of with me? Using the analogy? Love it. Hell yeah. So that delay or that block of the impulse will only allow it to travel in one direction. And it moves through a cycle throughout the heart tissue in a series of faster and faster depolarizations. You want a picture? You like pictures? Let's do pictures. Ready? There's a picture. So we have it caught in a loop. So we have this guy caught here. This is blocked. It is blocked. No. Can't sit here. Seat's taken. Me and Jenny was like peas and carrots. But what can happen is what? All right. We can have this guy come here and activate that muscle tissue and go back and forth, back and forth, back and forth, and generate this rhythm below me. That rhythm below me. Wow, that's pretty quick. That's a 6-second strip. Can you see? How do I know? I got my lines here. Also, I could count 30 blocks if I wanted. And I've also got 1, 2, 3, 4, 5, 6, 7, 8. What? Why you bother me? Wolff Parkinson White is a accessory pathway dysrhythmia that occurs through the bundle of Kent. So which there means there's a back door man that's sneaking that impulse through. You know about back door man, don't you? Yeah, you do. So he's a sneaky guy. And the gatekeeper is the AV node. We're going to learn a lot about him. The AV node blocks and holds an impulse for a reason. But this guy goes around the bouncer. And that's one of the reasons if you like try and dump some adenosine on a Wolff Parkinson White, you just got rid of the gatekeeper. So now who's running the show? That accessory pathway is now the only pathway, and he's going to take control. So we could put him in a rebound, dangerous, deadly tachycardia. Good question, though. I like that. Shows me you're thinking. At least one of you is. So moving on, we got another picture. I don't really care. That ain't gonna help you none. What causes it? Due to conduction delay or blocks, there's hyperkalemia that can cause it. Myocardial ischemia, certain anti-disrhythmic medications. You could have extranodal pathways. These rhythms will include atrial flutter, atrial fib, premature atrial complexes, and paroxysmal supraventricular tachycardia. What is PSVT? It's going to swing back and forth, but as you saw early on the monitor, it's going to eventually get caught in that one loop. Like, we're trying to include wrath in this. All right, back to me. Now we're back down. Eventually, I'm going to stop passing it to her because she can't catch good. Right? Literally and figuratively.
Yeah.
So now those are your reentrant dysrhythmias. There's unidirectional block going on. So the heart will get caught in a whole new rhythm that's generated by the atria. And oh, they're fun. So the first one I want to talk about is the picket fence sawtooth pattern of the atrial flutter. Atrial flutter will have a picket fence or sawtooth shark teeth appearance to it. These are no longer called P waves in between. You'll have QRS complexes, and then you'll have these big spiky looking things. These are called F waves. They are flutter waves. Flutter waves. It is usually due to a single irritable site in the atria that initiates many electrical impulses at a rapid rate. That means you could have a very fast atrial rate with the ventricles not matching it. If the ventricles start to try and match it, though, that's a flutter with RVR. What's RVR? Rapid ventricular response. Heck yeah. So atrial flutter is not a great thing, but it's even worse if we have the ventricles trying to catch up, because you can have an atrial flutter rate of what? 250, 300? It can be bad. There's no P wave left, and the atrial will produce some extremely fast impulses. So there will be no P wave. What will I have instead? A what wave? F wave for flutter wave. Here in a little bit, I'm going to talk about atrial fibrillation. We'll have F waves there too. That chaotic baseline is known as fibrillation waves. So remember, the AV node is the gatekeeper to the ventricles. Based on the number of impulses the AV node accepts, the ventricular response is established. What does that mean? Based on the number of impulses or balls I'm throwing to somebody, anybody, is what the ventricular response will be. But this also sets you up to realize that there is a conduction ratio. What is the normal AV conduction ratio? What do you think there, Baker? AV conduction ratio is normally what? Maybe I need to rephrase it a little better. So P wave to QRS complexes. What ratio do I have? 1 P wave, 1 QRS. No, I think maybe I worded it wrong. I'll take the blame. It wasn't like it was a cardiogenic shock patient. So conduction ratios mean that those F waves are actual atrial depolarizations that are occurring, but the ratio could be very, very different. You could have 2 flutter waves or 4 flutter waves. That means there's 4 atrial contractions for each ventricular contraction. That means the atrial rate could be 300 beats per minute versus a 75 ventricular rate. That sound fun? No. So, go ahead.
How is the AV node stop us from happening? Because when we were talking the other day about blocks, that was because their impulses were getting blocked because of ischemia, but that's not the case here. Is it because like they're coming in that absolute refractory period or something like that?
No, so the AV node has kind of carte blanche power to who he lets through and who he don't. He is the bouncer, and he can let impulses through at a very high rate of speed if he wants or needs to, but he don't have to. He can only let one at a time through. So atrial fib is multifocal atrial blitzing, which means that pretty much most, if not all, the pacemaker sites in the atrium are firing at once. And it creates a chaotic baseline, but you'll still see with AFib, there's a P, there's a QRS, there's a QRS, and in between it is crappy, and it's all irregular. But he only lets one slide through at a time, but he can't always, like, he's playing goalies. Now, sometimes one will slip through. For the most part, he can stop them. Most part. So A flutter with a slow ventricular response, less than 60. A flutter with rapid ventricular response, 100 to 150. Any faster than 150, it's going to turn into somebody else. SVT, because SVT is the umbrella term. SVT is the umbrella term. I like it. So next we're going to talk. Oh, you make my heart flutter. So rapid ventricular rate, you'll lose that atrial kick. Your cardiac output will drop. What is cardiac output? Yeah, stroke volume and heart rate. There's a risk of pulmonary emboli and cerebral emboli. With A flutter and AFib, you have a risk of emboli. Because at that speed, can all the blood get out? No, it's going to sit there. What does blood do when it sits? Coagulates. So guess what we form? Clots. Can also cause CHF, ischemia. Pretty bad stuff. Let's look at a couple. Ooh, how come my stuff don't work? All right, there we go. What you got? What do you notice about the regularity? Regular. You might be tempted to confuse AFib and A flutter. Here's how you don't. Look who's regular. AFib will not be regular. It's going to be all over the place. This thing, most of the time, will be regular. Plus, we have the obvious shark tooth flutter wave. So how would I call this? Let's see. The top rhythm. 1, 2, 3, 4, 5, 6, 7, 8. All right. Patient shows an atrial flutter with a 3-to-1 AV conduction ratio. Why is it 3-to-1?
Is that not a T wave and 2 T waves?
Nope. That is 3 flutter waves.
So the T wave just got lost.
He got absorbed. That's why that F wave right there is a little bigger. We had fusion occur.
So how do you know if it's, how do you tell if it's a T wave and 2 T waves versus 3 F waves?
So for that patient, I can see that first spike between the two is a little bit taller, but he also mimics the same shark tooth look as the other two. The morphology is the same, but he's a little taller. Why is that? He's got an extra wave in there. That makes sense? The morphology gives him a wave.
Because he said that's a 3-to-1. Yeah, like I just didn't initially understand why that was also a key.
Good show. You want to see a live one? Ooh. Where'd that come from? G Unit, that's right. This might be that call I ran with O'Neill where I yelled at her. Actually, it is. So I have what going on there? A flutter. How many flutters? 1, 2, 3, 4, 5, 6 flutters. That's a lot. You think? But the rate was okay. The blood pressure was okay. She was starting to feel a little bit syncopal. She said her chest was starting to hurt. Guess who walked them to me? We're not going to use names. Engine something, though. Whoever that was. Probably. Whoever over there by Joseph E. Boone. All right, it was 16 then. Let it be the record show. It was 16s. So, rate of 77. Do I need to bother it? It ain't broke, don't fix it. It ain't broke, don't fix it. Blood pressure's good. The only thing I was problematic was that they were having chest pain. So what would walking them do? Exacerbate it. What's that?
So what if they had it like a while?
Like if it's their normal. Then they are at risk for clots at that point. But how would they know? If it was an acute, like it just came on, like I feel funny kind of thing. Like I could annotate that, you know, they've had it for about 2 days. But other than that, I can't confirm that they've had a flutter for 2 days. Did they feel funny because they had the A flutter for 2 days, or did they develop the A flutter secondary to some other condition that caused it? Hard to tell.
And back out 2 consecutive days for the same place.
That's one of the things I loved about working in the big cities. I rarely saw the same person ever. Love it. You know, except for that one that used to come to Station 30 all the time. Take me to AMC South. No.
He's in the park. It's like a mile down the street.
It refused. Whitworth, you did? You can do some laps? Anybody got some cocaine for her? All right, let's talk about atrial fib. Don't be fibbing to me. AFib is one of the most common arrhythmias. People live with it every day. Millions of people have this. And you know this, man. Has 3 very distinct characteristics: a chaotic baseline, no discernible P waves, and irregular R-to-R interval. This is a result of atrial multifocal blitzing. Break that term down for me. Martin, tell me about it.
What was the term?
Multifocal atrial blitzing.
Sounds like where the issues are just firing off here at that.
Yep, pretty much every pacemaker cell they got is trying to send a signal through the AV node. So they're just like all firing and trying to depolarize at the same time. So what's that going to look like? The atria won't pump anymore. They're going to do what? They're going to quiver.
These are the people that live with this every day.
Every day.
Do most of them know about it, or is it something that commonly people just don't even know they have?
Depends on the person. Some people know they got it. Like, anybody ever tell you got a regular heart? Yeah, they told me I had a regular heartbeat. You know, it'd be one of them things. They will take a warfarin or a Coumadin or something, because they're going to have, if there's no pumping and it's just quivering, we're going to have congealing blood. They're at big risk for clots.
Constant, or they come on and off?
It usually depends on the patient. Most of the time, once it started, it's there.
Forever.
Unless it was an acute setting and the underlying cause can be fixed.
Tablets all the time.
Most of them do. An acute one would be more dangerous in my mind because they're not on the blood thinners. So let's take a look. The QRS complex are usually within normal limits, which means you'll probably most likely have a skinny QRS. There's multifocal atrial blitzing. The AV node's unable to handle all that. And the AV node allows impulses to enter the conduction system at complete random. So it'd be like if I had, let's say we take sloths, we put them at the front of the class, and we all get a paintball gun with automatic machine gun capability. But we give wrath a little shield. Wrath is the shield. Now, there's no way you could stop all of them, right? I mean, especially because, me shooting at chest level will be way over your head. So what I'm saying is that AV knows doing its best, but what gets by is completely random due to the sheer volume of impulses traveling of balls. Yeah. Let's take a look. Here's your questions answered. The ventricular rate's variable. If it's over 100, it technically is what? True. AFib with what though? There we go. Technically, if it's over 100 and I got AFib, it's RVR. So the rate could be variable. It's going to always be irregular. There are going to be F waves there. Instead of P waves, I got F waves. What does F wave mean? Fibrillation waves. Fibrillation waves. You fibbing me?
That's a hard word.
What? Fibrillation? I mean, if you got cat down, you could do fibrillation. So, hey, ladies, you ever had a man be irregular? Like he's blowing your phone up, texting every day, and he just fall off, starts to get inconsistent. He's irregular. You know why? He's fibbing. He got another woman.
That may be inconsistent.
Maybe. So, if it's inconsistent, if it's irregular R to R interval, then they are fibbing. Remember that. So, QRS complex usually looks pretty good. So, rhythm could be chronic in nature. It's commonly associated with underlying heart disease, possible CHF, rheumatic heart disease, hypoxia digitalis, electrolyte imbalances. Treatment, usually none. If the heart rate's good and they ain't showing no symptoms, let it ride. Monitor, transport. They used to give digitalis, but you can see where most of these rhythms are caused by digitalis. We don't care anymore. Does have a reversal agent named what? What? Digibind. You want to see one? Ooh, look, a dead body. All right, who do I want? Tyler, come tell me about it. To the board, good sir. Go through your 5 steps. Show me you know what you're doing.
Heart rate's 90. They do not appear to be the same distance.
Can you describe what you're doing?
Measuring the QRS complex. They're not all the same. And then you obviously your P waves are not fluttering, but fibrillating.
All right. So you've done laid out 3 criteria to identify this rhythm. What you got? Atrial fibrillation. It's written on the board. Good job. I get it. Here's what the temptation would be for you in the field. Huh, AFib. Is it though? I would tell you, don't be tempted by the easy button. While even it looks like AFib, it could be AFib. Verify by going through all 5 of your steps. Trust me on that.
So lead fib would be the QRS lead could in there also. It would have the normal QRS.
Say that again.
So instead of AFib, DFib,
Okay.
QRS look normal.
No, VFib, there's nothing there but quivering. Yes, sir. All right, how do you treat AFib? So the treatments we got here are when the rate's usually 150, 160 and above, okay? AFib with RVR is a rapid ventricular response. If they're stable, they don't have any complaints, no lightheadedness, no dizziness, no low blood pressure. You can contact medical direction and get a calcium channel blocker approved. You push the calcium channel blocker 0.25 per kg over 2 minutes. Normally knocks this thing on out. Second, if they're unstable, they got chest pain, lower blood pressure, can't breathe, all that mess. You can get some sedation on board, and then you can cardiovert. But the problem with that is what? All those clots like to jump out of the atria. You'll need medical direction for that, and if they'll allow you. What you got?
So.
It ain't gonna be able to see.
Is over 160, you're not gonna be able to see the atrial fibrillation, right?
Most likely, yeah.
So you just have to know, like, they would have to tell you, hey, I have an AFib. Basically, right?
Most of them wouldn't know. If this thing gets too fast, you'll probably end up looking at it like it's SVT.
Right, that's what I'm saying. So like, if you have to find a patient who was in SVT and you didn't know they had AFib, you try to cardiovert them.
Oh, well. I mean, how would you know?
Yeah.
But the treatment is cardioversion at the extreme level. If they're that extreme, then we have to cardiovert. The thing is if it's a patient that is not on blood thinners or it's, they're not treating it, there's a risk of clots. But what's going to kill them now versus what'll maybe be a problem later, the car's on fire, pull them out. Again, contact your local medical protocol there for that one. SVT. This often describes rapid, regular, supraventricular arrhythmias. When more accurate identification is impossible because P waves aren't visible and the rate is common to other arrhythmias, everything becomes an umbrella. Ella. What'd you call yourself? Did you call yourself a Riri?
No, I call myself the best student you've ever had.
What?
Or ever will have.
Your name's not Bigler. You're not the best student I've ever had.
Don't exist.
He does.
I'm here. Look at me.
I'm talking about Captain Bigler.
Oh, wait, where's?
I'm getting silly.
He wasn't 30, he made 30s in hospitals.
Truth. Let's talk about it. So umbrella term. Why is it an umbrella? Ella. Martin, tell me about it.
I guess it's kind of everything going on.
At a certain speed, the ability to identify it as anything else is gone. So SVT with overlapping rate changes and ranges could be anything from sinus tach that got too fast, atrial tach that got too fast, atrial flutter that got too fast, junctional tach that got too fast. This guy encompasses all tachydysarrhythmias in which the heart rate's over 100. Any tachycardic rhythm that originates above the ventricle. How do I know it comes from above the ventricle? It's skinny. If it's big, wide, and juicy, it's originating the impulse from below and from the ventricle. If it's skinny, it's coming from above the ventricle, hence the term supraventricular tachycardia. What about a supraglottic airway? Is it in the glottic opening, below it, or is it above it? Your IGL sits above the glottic opening, not down through it. So any rhythm originating from the atria will be skinny. That's how you know it's from the atria. And the term paroxysmal means to sudden onset and or cessation. We saw an example of the paroxysmal SVT earlier when I pulled the monitor out, right? So it went from a supraventricular tachycardia back to like a sinus tach and back and forth for a little while. So how does this occur? Why is it happening? Well, cocaine can do it, and cocaine accessories. Excuse me. So when a rapid atrial ectopic focus or foci, what's the difference? Is one singular and one plural? All right, very much so. So when atrial ectopic focus overrides the SA node and becomes the heart's primary pacemaker. Look at me. I'm the captain. That's all that happened. They took over. And it can resemble a rapid sinus tach, but sinus tach does not normally exceed over 150. So how do I know it's a supraventricular tachycardia? Well, there will be a rate that is faster than 150. The rhythm will be regular. There is no P waves. The PR interval is not there. And the QRS complex is the big key. It is less than 10. less than 0.10, so less than 3 blocks. It's skinny. It's fast as hell, boy, but it's skinny. If it was wide, it'd be originating from the ventricles. Every year I say that. Every year, some of y'all just mistake it for the other one, which is VTAC. I get it, but let's avoid that. Talk to me. Who wants it? All right, Chief, let's get it. Come walk me through them 5 steps. Again, obviously, I've got the answer on the board, but as you can probably tell, there will be lots more of these without the answer on the board. I got a whole 100-something thing PowerPoint with just rhythms on it.
Over a 6-second strip, you're gonna see that the R ratings are regular. They determine the rate by counting the R ratings.
That's right.
You could, do it this way with the points or the calipers.
Okay.
All regular going across.
So I got a rate over 150.
You rate of 150, so it's over 15 of them.
That's right.
Across. What's it's showing here is that there's no P-waves, so it's not even,
Where'd the P waves go?
they blended in.
They fused. They're all up in that T wave now. Very good.
So it's going so fast that it's not even, charging the atrium. It's pretty much just charging the ventricles, so you see the SQRS
Okay.
repeatedly. And it's just going, like, the AV node is taking over as a pacemaker, so it's shorter distances,
Some pacemaker in the atria is taking over. So what about my PR interval? Does it exist?
there's no PR.
None.
So there's.
What about my QRS complex?
It's less than a normal rate, so less than 12.10.
This is less than 0.12, so it's skinny.
Yeah.
We call this narrow complex tachycardia versus wide complex tachycardia. So if it's wide complex, it's ventricular. If it's narrow, it's atrial. So this guy is SVT. Very good.
It's always gonna be unstable.
Well, it will start off. Sometimes it can start off as they can compensate for a little while, right? But eventually, yes, it will be unstable. What can do it? Overexertion, stress. Uh-oh. Hypoxia, excessive use of stimulus. Uh-oh. Hypokalemia. Next slide. Somebody asked me what that word was. I don't know. I don't know what ASHD is. So if they are more towards the stable range, we could try vagal maneuvers, stimulate that vagus nerve, release acetylcholine, slow that heart rate down, bearing down, coughing, squatting, carotid massage. There's also some new thing I learned today about flipping somebody around like a WWE move or something. That looked pretty fun. Drug therapy, such as adenosine, could be an option, or synchronized cardioversion. So medicine versus Edison. When would you choose to differentiate between medicine or Edison? What do you think there, Rath? Tell me about it.
And we don't eat food in sense.
I didn't hear you. What'd you say? I don't think anybody heard you.
If the heart is not beating, you will use Edison.
Well, so if the heart's not beating, I'll use Edison. No, I will use CPR. No, I only shock pulseless VTAC and VFib. So I've got SVT with a patient talking to me. He's alive.
Is that the same thing as pacing? Can we get that right?
No.
It's not.
Pacing speeds you up, cardioversion slows you down. So synchronized cardioversion is used for a patient with a rate that's too fast. I need to use a very invasive electrical maneuver to work on. So that's Edison. I want to slow them down, but I don't have to be that invasive. If they're more stable versus unstable, like let's say Martin right here's got a heart rate of 190. Heart, feel fun today, man. I was in this coke house last night and I don't like coke house, I like the way it smells, you know? So he's got a heart rate like 190, but his blood pressure is good. He's not losing consciousness. He don't have chest pain. He's doing okay. He's more stable. We could talk about vagals, adenosine. But what if he has a low blood pressure? He's got chest pain. He's starting to lose consciousness. He's unstable. Pad, sync, zap. Thanks for choosing Georgia Power for all your lovely needs. So my decision is based on my clinical, the patient's clinical presentation, stable versus unstable, symptomatic versus non-symptomatic. If he's just sitting there with a heart rate of 190 with no other symptoms going on, not symptomatic. If he's got a low blood pressure, pale, cool, clammy skin, chest pain, difficulty breathing, and terrible LOC, level of consciousness, he is hemodynamically unstable. He's gonna get the zap. He's gonna get the juice. Is everybody following me? So how often do you think vagal maneuvers work?
10%.
25% of the time. 25% of the time. But I'll take bets. So 25% of the time. So all this is data you can look up, but vagal maneuvers do work, but only 25% of the time. I've never seen it work on a senior adult. I don't know if they didn't wore that nerve out or what's going on, but it doesn't seem to work as often on older patients. Matter of fact, in my 14 years of being a paramedic, I ain't never seen it work on an older patient. I don't know why, the who, the what. I'm just telling you, sharing with you my experience. You paid for this book. You paid for me. Poorly paid for me. You got no.
Consider a older.
Blew my eye. That one. You know him, Walters or Harden. Any of the old ones in here, they'll be fine. What? All right, so let's say anybody over 60, 65. Deal?
Yeah.
Let's talk about it. Hey, look at that. Stable versus unstable. What do? You can try stable, vagal, adenosine slam, followed by a big flush. You need a good, strong IV, probably AC. Hey, you know, when I know y'all don't like EJ because y'all snitch on people, but my favorite spot to do on adenosine is an EJ. You know why? Because it dumps right into the heart. It's my favorite. So honestly, just between us, you know, I know I'm recording, but I like EJs for adenosine slam. ACs are cool too. I like EJs because they dump right into the heart. Next, we would consider what? The unstable patient. Consider sedation. You don't have to do it, but consider it. And then do a synchronized cardioversion. Synchronize and cardiovert. So tell me about Wolff-Parkinson-White. Pre-excitation refers to early depolarization of ventricular tissue due to an accessory pathway. So Wolff-Parkinson-White means there is an accessory pathway known as an extra bundle of tissue that forms a connection where? I said it earlier. So there's an extra connection between the atria and the ventricles. This is known as AV reentrant tachycardia. It can identify, Wolff-Parkinson-White can identify with a delta wave. See how that wave up there looks like a delta tail wing? So the delta wave is characterized by a QRS greater than 0.10. So it's a big wide QRS. It's got a shortened PR interval and a slurred Q wave. So let's look. Slurred Q wave meaning what? The Q, or the beginning part of that big spike, is slurring, causing that little curve there. Because of that, it widens the QRS complex, and because of that, it shortens the PR interval, giving us the three identification characteristics of a Wolff-Parkinson-White syndrome. So the QRS is greater also due to the ventricles being stimulated by impulse originating outside of the normal conduction pathway. So because a impulse is generated outside of the conduction pathway, like SAAV, bundle of His, bundle branches, and the Purkinje fibers, we're going to see the QRS widen just a bit. Not a whole bit, but a little bit. So what are my three criteria again for Wolff-Parkinson-White? Shortened PR interval, widened QRS, and a slurred Q wave. Slurred Q wave. You don't see one? Tell me about it. This is a slower one, yeah. It's only real dangerous when they have rebound tachycardia. Right now, if that patient was in front of us, he's got a heart rate of 50. It's regular. P waves are there. We do have a slurred Q wave, widened QRS, and a shortened PR interval. It's Wolff Parkinson White all day, but is it causing my patient problems? Do I have to fix it? Or does he just walk around like this every day? Most likely he just walks around like that because he has that accessory pathway. To fix it, they'd have to perform an ablation. What's that? They'll guide a wire up there. They'll heat it up and they'll burn that thing off.
Is the inverted T wave separate thing? Inverted T wave?
So because it is it's having to repolarize via a retrograde, it's going to be going backwards. It's going to repolarize in a different method than it normally would. Why? Because we're not following the conduction system like this. We're going around the way. So that T wave will look different, be absent, or be inverted because the repol on this guy is affected by that because having to go to a different vector. Does that make sense? More information that you will probably find useful or useless. So the T wave generally defected the opposite direction of the delta wave and the QRS complex. Again, that has a lot to do with its repolarization. So EKG features are short PR interval, the delta wave appearance, the morphology, widened QRS complex, and of course, the slurred Q wave. Other notable mentions. We've got digitalis effect, the sag. We talk about that either. The dig sag there right after the QRS. That segment sags a little bit. Why? They've got digitalis toxicity. If only we carried a drug for reversal agent. Digibind. There's your Wolff Parkinson White delta wave again. And just another honorable mention is the Osborne wave or the J wave created by hypothermia. The J wave is created by hypothermia, Osborne or J wave. I've only seen that question on registry once. It was just asking what EKG finding would you accept find a patient who's hypothermic, and it was like, oh, look, J wave, man. Everybody with me? Hell yeah. So nothing really changes for us there. Just going back over the treatments. Again, at the end of the day, man, if it's too fast, slow it down. Like you got options there. Are they stable or unstable? That's the first thing you need to ask your patient. And by ask them, I mean you find out their vital signs and then you direct your care and treatment based on your findings. Your assessments, if they're accurate, will help you determine what course of action you need to take. So what does that look like? That looks like you actually assessing your patient, getting a blood pressure, getting a feel for their breathing, their chest pain, if they got any LOC, if they got pale, cool, clammy skin. What is their perfusion status? Is it a rate-dependent issue? So stable, SVT, vagal, adenosine, try. If that don't work, we cardiovert. Unstable, goes right to cardiovert. Stable, VTAC. We're ahead of ourselves here a little bit because I haven't got to ventricular rhythms, but just for your own fun and amusement, a stable VTAC, you can try amiodarone, procainamide, sotalol. You have pharmacological agents that can stabilize that VTAC. Unstable VTAC, you need to go ahead and cardiovert so they don't die. So they don't die.